Well, the case of competition doesn't rest on how wonderful competition is, because competition isn't wonderful. It's terrible in many ways. And it has some awful consequences as well as some beneficial consequences. The case for competition depends really on the failures of the other ways of doing it. As those of you who've read some of my stuff will know, I argue there are basically 4 fundamental ways of delivering a health service, which I call trust, mistrust, voice, and choice. Trust is essentially when you trust the professionals. You hand it over to the professionals, to the providers, the professionals, the doctors, the nurses, the managers, and you basically allow them to make the major resource allocation decisions. Hand it over to them. Good way, in many ways, it has many advantages as a way of doing things. People like being trusted, good for high morale, but it does have a problem with it, which it does assume that everybody in it is working not in their own self-interest, or indeed the interests of their institution, but are behaving as what I call a perfect altruist, a knight, I've called in some of my terminology. If there is any element of self-interest, or if there is any element by which people are pushing the interests, say, of their own institution, working in that environment, the trust model begins to break down, and we get under-responsive services organised more in the interests of the providers than in the interests of the users. The alternative, one of the alternatives, is mistrust. And mistrust is when the government decides it doesn't trust any of the providers, and it tells them what to do. And the version of mistrust model that we've tried in this country, and incidentally we've tried all of these models and they all failed. We tried the mistrust model. The version we had was targets and performance management, where essentially we set targets and then we rewarded or penalised the people who achieved the targets or the people who failed the targets. Also known, of course, as, in the jargon as targets and terror. The interesting thing about targets and terror was that it basically did work. Unlike perhaps the trust model, it worked. It worked at least in the short run, and lost in the furore over targets and all the rest of it was the fact that actually the NHS rather successfully met most of its targets. But there are problems with targets. You're ticking them off in your head, I'm sure, as we go through, the distortions that they create in resource allocation, the demoralising effect that it has on professionals. Professionals aren't used to being told what to do, don't like being told what to do. And the gaming that goes on, the sort of distortion of the numbers, the playing around with the numbers, the fiddling of the numbers in various ways so as to achieve the target ends. So again, not necessarily an ideal way to proceed. Voice is when you use the instruments of either individual voice or collective voice to try to lever up the quality of the service you're provided. So, I mean, patients might go and actually use their voices to complain to their GP or their hospital or whatever, or they might go on the board of the hospital, or there might be petitions, they might go to consultative fora, they might talk to their elected representatives, use the instruments of democratic accountability. Voice, again, has many advantages as a way of doing things. It's rich in information. It gives information, maybe somewhat distorted information sometimes. It gives information to the providers about what they're doing wrong. My chief problem with it is that I think that it's basically, it favours the better off. It favours the more articulate, almost by definition. That's what a voice is, the more articulate. And it's also an often extremely clumsy mechanism for trying to for trying to lever up quality. I don't know if anyone's ever tried to level a complaint or use a complaints procedure, which is one of the instruments of voice, against a hospital or a GP practice. It's a nightmare. I know because I was on the other side of it once, because I was on the board of a hospital and I was given the complaints convener job. And boy, did we make people jump through hoops in order if they wanted to complain, and then we turn them down. Finally, choice, user choice, patient choice coupled with provider competition. has, as I say, many problems with it, and I'm sure we shall air some of those problems as we go through, including problems about information, just as with voice. You want to have your patients properly informed and so on for choice to work. On the other hand, it does provide certain incentives for institutions and the individuals working in those institutions to achieve their proper ends. And to lever up quality. And indeed, one of the interesting things is we're now getting a certain amount of research, which some of you will be familiar with. There's research done by Zach Cooper at the LSE, who I should declare an interest was my PhD student, and Carol Proper at Bristol. Declare an interest. At one point, I employed her. I think I gave her first academic job, actually. Anyway, and they both come out, they both use similar data and similar techniques, and mirabile dictu, they have come out with similar results, which is wonderful for social science, although it's pissed them all both off royally. And the results displayed that on the whole, that competition, that hospitals in more competitive areas have done better at levering up quality than hospitals in less competitive areas, and that tends to reinforce the evidence that's come out of the United States, which is rather similar. Certain forms of competition don't work. Price competition, which unfortunately is in the present bill, or the possibility of price competition is not desirable. Most of the evidence tends to suggest that tends to lower quality. It does lower costs, but it does tend to lower quality as well, and I don't think that's really politically acceptable at the point. Where does integration fit into this model? Well, integration is, I would argue, basically a form of the trust model. It is basically trusting institutions to work together in a collaborative fashion to provide better, quote, integrated care. If it works, if it was to work perfectly, if we lived in a world that was staffed entirely by knights, in which institutions and everyone would just sit around the table and decide purely on the basis of this is purely in the interest of the patients, it would be by far the best system. I don't think that happens. There is one form of integration, though, that I would support, which is budgetary integration. I think the idea of the agent who is responsible for, e.g., referring people to hospital, the idea that they also have to bear the resource consequences of that particular cost, and they can also act as an agent for the patient in terms of integrating or coordinating the care of the patient, seems to me quite very desirable, and of course that is one of the reasons why I'm supporting the present move towards GP commissioning. So, competition, provider competition good, quality competition good, price competition not so good, provider integration bad, but budgetary integration good.